And all the participants must pay attention of Ladies and gentlemen, welcome to the International Guest Lecture. And we would like to remind you that the opening ceremony is going to begin in a few minutes. So please be ready. We still have about 3 minutes. So please, ladies and gentlemen, to prepare yourself and please be ready. And we would like to remind you that there will be a link that needs to be filled by each participant, and the link will be sent to the chat column. So please kindly check your chat column. Para peserta dipersilakan untuk mengisi link yang dikirim melalui kolom chat. And for another information, we would like to inform that all the participants have to name their Zoom into a format of name_institution. Kepada seluruh peserta yang belum mengganti namanya, diharapkan untuk berkenan mengganti nama Zoom dengan format nama_instansi. Once again, we would like to remind you to rename your Zoom account into a format of name_institution. Dan para peserta yang belum mengganti nama Zoom, diharapkan untuk berkenan mengganti nama Zoom. And then, we would like to remind you that all the participants are expected to use a virtual background that will be sent into the chat column. So please kindly check your chat column for the link and also for the virtual background. It's already 3 p.m. in Indonesia. So, Professor Torres, may we start the agenda, please?
Can I
Hola,
start?
yes.
Can I start
Okay.
my lecture? Yes.
Okay.
Okay.
The Honor Professor Antoni Torres Marti, Medical Doctor PhD FEPRS FCCP ATSF from University of Barcelona as our guest lecturer today. Hola, Profesor Torres.
Hello, hola.
Hola, muchas gracias por su disposición como nuestro profesor invitado. Thank you, Professor, for your willingness as our guest lecturer today.
Thank you very much.
Okay, thank you, Prof. Also, to the honor our Dean, Professor Dr. Reviono, Medical Doctor, Pulmonologist Consultant, Fellow of Indian Society of Respirology.
Yes.
Thank you, Professor. We also would greet to the honor professors, pulmonologist consultant, and all the resident doctors, also beloved participants. We are delighted to welcome you international guest lecture titled New Guideline of Severe Community Pneumonia, conducted by Pulmonology and Respiratory Medicine Department, Faculty of Medicine, Universitas 11 Maret, and Dr. Muardi General Hospital. To start with, we thank God for His blessing and mercy, so we can attend this international lecture. I am Tiur, a pulmonology resident doctor, and also your host in this event today. Today's international lecture is special because we invite an expert in pulmonology, respiratory medicine, and intensive care unit. This event will be held for about 2.5 hours. First, it will be opened by an opening speech from our dean, Professor Dr. Reviono, Medical Doctor, Pulmonologist Consultant, Fellow of Indonesian Society of Respirology. And then second, it will continue with a lecture and discussion from Professor Antoni Torres Marti. And it will be moderated by Mrs. Atri, Medical Doctor, Pulmonologist Consultant, Master of Biomedicine. Last, it will be closing ceremony. Let's begin to the opening remarks by our dean. To Professor Dr. Reviono, Medical Doctor, Pulmonologist Consultant, Fellow of Indonesian Society of Respirology, time is yours.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to distinguished speaker, all our colleagues, students, and all participants. It is my pleasure to welcome you to this international guest lecture on the topic of severe pneumonia. First of all, let us pray and praise to the Almighty Allah Subhanahu wa Ta'ala. Because of His bless and mercy, we can come together with any obstacle with a healthy condition. In today's event, the international guest lecture. The second, let me express my deepest gratitude to all participants who have taken their precious time to attend this lecture. In particular, I would like to express my sincere appreciation to the invited lecture from Hospital Clinic, University of Barcelona. Today, we are very lucky because we have a well-known, a world-class expert speaker who has a very high H index. Thank you very much, Professor Antoni Torres, MD, PhD, FCCP, for your willingness to share your expertise in critical illness of pulmonary infection. Good morning, Professor Torres.
Good morning.
Yeah, nice to meet you.
Nice to meet you.
Yeah. very high H index. This means that he has many followers among fellow researchers because his paper article is widely cited by researchers in international journal. Okay, do not waste this opportunity to discuss directly with him. These international lectures bring us updates and potential issues on the new guidelines of severe community-acquired pneumonia. Pneumonia is an infectious disease that is great concern the world population. All pandemics start with pneumonia. The last example is COVID-19. It seems that human and microorganisms are competing to beat each other. Microorganisms try to become resistant to various kinds of antiviral and antibiotic and others. Well, humans are always trying to perfect the management of infectious disease. On this occasion, Professor Torres will present for the management of severe pneumonia. I do hope that all of you will gather in a fruitful discussion and sharing that encourage knowledge and technology transfer. Hopefully, this lecture can contribute to answering questions and problems around cases of severe pneumonia. For example, pneumonia with sepsis or with respiratory failure that we experience as and can trigger other breakthrough in this topic. Okay, and for the closing, I, as the Dean of Faculty of Medicine Universitas Maret, would like to thank the committee for organizing this event. And finally, I hope that you will, and for all participants will enjoy this lecture and gain the most benefit from it. Have a wonderful lecturer. Wassalamualaikum warahmatullahi wabarakatuh.
Can I go ahead?
Yeah, MC, Master of Ceremony.
Okay, Prof. Torres, maybe before you start your lecture, would you please, if I read your curriculum vitae to the participants?
Excuse me, this is a question
Yes.
for me? Yeah.
Oh, yeah. I would like to read your curriculum vitae to all the participants.
Okay. Thank you.
Okay. Yes. And before that, maybe there's a screenshot for our photo session that will be organized by the committee.
Okay. Before we go further into the main agenda, we will go to the photo session. I would like to ask everyone to turn on your camera, and the committee will take a screenshot of the attendance, and other committee will take a picture for the online session in the Pulmonology and Respiratory Medicine department. Okay, I will count. Are you ready? Please open your camera, turn on your camera. Okay. 1, 2, and smile. Slide 2. 1, 2, and smile. Slide 3. 1, 2, and smile. Slide 4. 1, 2, smile. Slide 5. 1, 2, and smile. And the last one, slide 6. 1, 2, and smile. Okay. Thank you all. And finally, to the main agenda, to invite Mrs. Atrin Adiputri, Medical Doctor, Pulmonologist Consultant, Master of Biomedicine, for moderating lecture. Mrs. Atrin Adiputri, Medical Doctor, Pulmonologist Consultant, Master of Biomedicine, is a lecturer in Pulmonology and Respiratory Department. So, to Dr. Atrin, time is yours.
Okay, thank you, Dr. Tiyu. Good afternoon, dear participants, professor, doctors, and colleagues. Also, Good morning, Prof. Torres. How are you?
I'm okay.
Okay. Yes. Okay, I am Artrin Adiputri, and I kindly request permission to serve as moderator for this guest lecture until the discussion session. And welcome to the international guest lecture featuring Professor Antoni Torres, MD, PhD, FEPRS, FCCP, ATSF. He will be speaking on the topic of new guidelines of severe community-acquired pneumonia. And we are privileged to have Prof. Torres here with us today. Actually, we already met, in 2016, Prof. Yeah,
Exactly.
at Hospital Clinic de Barcelona nearly 7 years ago, along with Dr. Farih Raharjo, a pulmonologist. We had the opportunity to observe there for a month and gain invaluable experiences. We witnessed the teamwork at the Respiratory Intensive Care Unit, or RICU, participated in case discussions, also attended scientific sessions and interacted with the research teams, and with all of which you were actively involved in. Okay, Prof. Torres, please allow me to present your impressive curriculum vitae. Okay, Professor Torres, now he's about 68 years old. Okay, he's a senior consultant of the Respiratory and Intensive Care Unit, Respiratory Institute, Hospital Clinic of Barcelona, Professor of Medicine, University of Barcelona. For education, finished his degree in medicine 1977, and then continue with residency in pulmonology in the Hospital Clinic of Barcelona. Also finished his doctoral thesis in 1983 and become a master in hospital management in 2001. For the career, he has had a distinguished career at Hospital Clinic of Barcelona from then to present, such as director of the Clinic Institute of Pulmonology and Thoracic Surgery, and then head of the Department of Pulmonology and Respiratory Allergy of the Hospital Clinic of Barcelona, also chief of the RICU, and then a full professor of medicine at Faculty of Medicine at University of Barcelona since 2009. Also, most relevant positions in medical societies from then to present. He is a president of he was the president of the area of tuberculosis and respiratory infection, and then also president of the area of respiratory infection of the Latin America Thorax Association, a chairman of the Respiratory Intensive Care Assembly of the European Respiratory Society, chairman of the Microbiology and Tuberculosis Infection, nominated for the vice presidency of the European Respiratory Society, and many more. And he also supervised 42 international fellows around the world in the last 5 years. And for the researchers, he's a director of 42 doctoral theses, and he is a national and international physician of reference in respiratory infections, invasive and non-invasive mechanical ventilation, and ARDS. Also have participated in research fellowships in Hospital of Boston, Harvard Medical University, USA. And he has so many articles, about 550, and then become a coordinator of a research group of 2063 of the Institute of Biomedical Research, August P. Instunier, or IDBAPS. Also become a coordinator or the head of another projects. And then he participated in 68 publicly funded research projects, become many projects leader, and then also participate in 15 European Union projects, and become a member of editorial board of some Scopus Index journals, such as American Journal of Respiratory and Critical Care, CHEST, and so on. And then so many awards, so many awards that were given to him, such as Edward Chanoff, and then Joseph Treta Award 2001, Award of the Foundation of Healthcare Sciences, also Lilly's Foundation Award, Award of for Professional Excellence in Investigation, ICREA Academia, nominated by IDBAPS the last 5 years, and the current one for the National Research Award of Catalonia. Of course, become a honorary member award of European Respiratory Society in 2019, and he he was the president of the 2020, 21, and 22 World Congress of Bronchiectasis. Really an extraordinary resume indeed. And it is an honor for us to have you here, Prof. Torres, especially you will be presenting the topic of guideline for severe community-acquired pneumonia, which currently lacks a specific and dedicated guideline before. To my knowledge, this journal has just been published, making it an extraordinary opportunity for us to directly hear the guidelines from its author. And during the presentation, I inform all the participants, if you have any questions, please feel free to write them directly in the chat column using the following format: name, institution, and the question. We encourage questions to be in English, but if you find any difficulties, we will assist in translating them into English. Very well, without further ado, let us listen to the lecture by Prof. Torres. Prof. Torres, the time is yours. You may share screen your slide presentation.
Okay, can you see my slides? Yes.
Not yet.
Yet?
Not yet.
Not yet.
Yes.
Perhaps are you seeing this one?
Wait.
Perhaps I have to share again the screen.
Okay.
Hold on.
Yes. Please. Okay.
Okay,
Wait.
now here it is.
Okay, we can see your slides. Slideshow, please.
And
Yes,
full mode.
perfect.
Okay, so thank you very much. Good afternoon. I want to thank the Artri and Adiputri for contacting me and for proposing me to give this lecture. I met him in the 2016, and as I have something that reminds me her every summer. She knows that very well. Huh? Okay, this is a secret. Okay, and thank you very much to Professor Reviono, the Dean of the University Ceballos Maret, well, the pulmonology program, and it is my pleasure to be here to talk with you and to talk about this recently published severe community-acquired pneumonia. So, salam alaikum. I am intensivist, I am pulmonologist, and I am professor of pulmonology medicine at the University of Barcelona. These are my disclosure of interest. And let's start with this slide about some data in the epidemiology of severe community-acquired pneumonia. I'll start with that. And this is data that we published in PLOS 1 2018 about our experience in severe community-acquired pneumonia before COVID. And you look at here, you can see that 30-day mortality in patients without shock or invasive mechanical ventilation was 16%, with shock alone, mainly septic shock, 25%, needing mechanical ventilation, 30%, and when you combine invasive mechanical ventilation and shock, 38%. So a very high mortality, higher than the mortality predicted by the Apache, with a median of length of stay high, really, and that represents a real burden for the hospital and for the society. And this coincides more or less with what was published in United States. This is data from United States, published by Rodrigo Cavalazzi in CHEST 2020. And they look at it, severe community-acquired pneumonia in Louisville, Kentucky, in a multi-center study, and they compare this data with overall data in United States for administrative databases. And you can see here the 15-day deaths, the 30-day deaths, the 6-month deaths, and 1-year deaths. And overall, the data is similar to us. And but look at here what is important. Part of these patients die during the year after discharge. And if you look at here, this is divided in early ICU admission, late, and total. And the percentages go 45 and 51 for the 1 year death. What about the microbiology? And this is before COVID again. The microbiology of severe community-acquired pneumonia. Again, this is from our study, published in PLOS ONE. And we divided the patients as regards the etiology and non-invasive mechanical ventilation and invasive mechanical ventilation, those needing invasive mechanical ventilation. And around 50% of the patients had not a defined etiology. Streptococcus pneumoniae was the most frequent one, 55% and 56% of the defined etiologies. Legionella represented around 9% and 2% here, and we take into account Legionella in our Mediterranean area. Respiratory viruses represented 14 and 21%. I am sure that now, with the molecular techniques and platforms that are available, this percentage of virus could increase or might increase a lot. Importantly, well, very few really atypicals, Coxiella, Mycoplasma, and Chlamydia. This is more frequent in the outside patients, but around 12% here and more here of patients with Staph aureus, mainly methicillin sensitive, and Pseudomonas aeruginosa. When we go to polymicrobial associations, and that means the association of virus and bacteria, or bacteria and bacteria, the percentages were 14 and 24%. And it seems that these polymicrobial causes had worse prognosis as regards previous publications that we had in critical care. But again, they were more frequent in mechanically ventilated patients. Staph aureus, Pseudomonas, and other difficult to treat microorganisms are important because the standard of treatment does not fit with the effective treatment of these microorganisms. And this percentage varies from country to country or to region or continent to continent. Is something to be discussed. Some European data about SCAP, comparing USA, Canada, France, Germany, Spain, and Italy. In this column, you can see the incidence per 1,000 population per year, per 1,000 inhabitants, and the severe CAP incidence. For example, here in USA, 2.5 to 7 per 1,000 adults per year. In Canada, 5 to 7. In France is apparently less, more in Germany, less in Spain, and less in Italy. And this is because probably the definition of severe community-acquired pneumonia is not totally uniform and homogeneous for the different studies performed. I don't know the data of your country, but perhaps this is something for the discussion. Again, the incidence, it depends on the resources available. This is very important, the ICU resources available. Today, I am going to use two documents. The first one is the Clinical Practice Guidelines of the American Thoracic Society and Infectious Disease Society of America. The first author was Joshua Medley, and they were published in 2019. because I need this for some of the aspects. But the second one, of course, will be the recently published, I think 1 month ago, the Severe Community-Acquired Pneumonia Guidelines published in Intensive Care Medicine and the European Respiratory Journal. Let's start with the criteria to define severe community-acquired pneumonia, and this is important for the reasons that I said. You can have patients with this criteria in the ward, especially with the what is called minor criteria, and sometimes vice versa. You can have patients that are not severe or do not have severe CAP, and they are in the intensive care unit or in the intermediate care unit. So nothing is perfect. The ATS-IDSA guidelines define it, and they used the 2007 criteria to define severe community-acquired pneumonia. Major criteria were the septic shock with need for vasopressors. Perhaps this could be now with the definition of the new definitions of sepsis should be modified, or respiratory failure requiring mechanical ventilation. And I think this could be also discussed because now we use non-invasive and mechanical ventilation. And they defined 9 minor criteria that include respiratory rate higher than 30 breaths per minute, a PaO2 FiO2 ratio lower than 250, the presence of multilobar infiltrates, confusion or disorientation, uremia that can be extrapolated to a figure of creatinine higher than 1.2 milligrams per deciliter, leukopenia less than 4,000 cells per milliliter, thrombocytopenia less than 100, hypothermia 36 of the core temperature, and hypotension requiring aggressive fluid resuscitation. If the patient has 3 out of 9 of these criteria, the guidelines define it, him as having severe CAP. And for the recent European published guidelines, we wanted to be practical, and we defined it, severe CAP, as community-acquired pneumonia patients that haven't been admitted to the ICU. But again, as I said, nothing is perfect, and it is very difficult to pretend that all patients with severe CAP in the hospital are in the ICU and vice versa. Again, you can see this criteria here, the ATS, ADSA. Well, these were the 2000 criteria, 2007, and the same were in 2019, sorry, the major and the minor. But I want to point out a couple of criteria that can probably have to be revisited. And one is the multilobar infiltrates. Multilobar infiltrates means 2 or more lobes involved. And if you take into account this definition, when you have 2 or more lobes, this can be bilateral or unilateral. We look at this in this publication, European Respiratory Journal by Adamantia Liapico, and we found that only bilateral infiltrates and then multilobar, no, it's 2 or more, is associated with a worse prognosis. And probably we should change this parameter. They did not in the 2019. Another issue that is not included in the minor criteria is lymphopenia. Now we know after COVID or during COVID that the number of lymphocytes is associated to a worse prognosis, and this is very clear. But we look at this in 2017 in a large series in 2 hospitals, the figure of lymphocytes at admission, and we found that this threshold that can be a little bit artificial, because the best thing is to know the evolution of the lymphocytes. But 724 lymphocytes per milliliter, or less than that, was associated with twofold risk of mortality. And the other patients have better outcome. It's a very simple parameter that you can determine at the emergency department, and probably should be updated in future, should be included as a factor in future guidelines. Well, this is the document that was published, I think, 1 month ago, and the chairman of these guidelines were Ignacio Martín Loeches and myself. And you can see here all the participants, and the European Respiratory Society was the trigger for these guidelines. The European Intensive Care Medicine Society, the European Society of Clinical Microbiology Infection, and we included the Latino American Thoracic Society of Thorax. It is very close to us in Spain and represents a pulmonology society for all Latin American. So in Latin America now they have these guidelines as well. It is important. What was the reason to do guidelines for severe CAP? Well, the different issues of severe CAP in previous guidelines were included in a document for community-acquired pneumonia overall, and they could not review in depth all the aspects. The second issue is that the mortality of severe CAP before COVID was really unacceptable, and the third, because we wanted to improve the outcomes of the patients. Guidelines were a little bit stopped, well, 1 year because the pandemic, but finally we could finalize, and I want to thank the societies and all these authors that probably you know their names. They are really experts in intensive care, in respiratory infections and microbiology. For doing these guidelines, we use it, and this is imperative by the different societies. Now, if you want to do guidelines, you have to go through this. You have to use the grade system that divides the recommendation in several grades, and then you have to use the PICO system. The PICO question is something that means a question that refers to an intervention into the management of the patients that can change the outcome or not of the patient. At the beginning of the guidelines, when we started, the panel defined 8 questions. For each question, you have to do a meta-analysis. It is not possible sometimes because for some questions you only have observational studies, and for others not even observational studies. And let's start with the first question that was agreed by the whole panel at the beginning. The question is, in patients with severe community-acquired pneumonia, does adding a specific rapid microbiological techniques to current testing of blood, respiratory tract samples, and urinary antigens as well, enhance the frequency of an etiological diagnosis compared to the conventional methods alone? At that time, when we performed the search, the scientific search, we could not find randomized clinical trials, and we had to go to observational studies. The recommendation is of moderate quality of evidence, is a conditional recommendation. And it says if the technology is available, a lower respiratory tract sample should be sent for multiplex polymerase chain reaction testing whenever non-standard S-kappa antibiotics are prescribed or considered. Remarks: if the SAE is ordered, the PCR, antibiotic management should be guided by the results. This is good practice statement. If the MEK-A gene in MRSA is not detected, empiric therapy should be stopped against MRSA. This ungraded good practice statement. If the CTXM gene is detected, empirical treatment should be escalated to an alternative gram-negative agent with activity against extended spectrum beta-lactamases. Ungraded good statement. And finally, if either Pseudomonas aeruginosa or Acinetobacter is detected by these methods, empirical treatment should be escalated to antibiotics covering these microorganisms. Of course, the problem of this question of the recommendation is these multiplex tests are not available for everybody in all parts of the world. And I understand that. I receive or I revise a letter to these guidelines saying that our questions are only representative for the USA and the Europe patients. And this is something that we can discuss after that in the question time. Let's do some review of these methods. And this is from a Renoir and Kolev published in the 2022 in this monographic Seminars of Respiratory Critical Medicine about HAP and VAP. Now, in our hands, in addition to metagenomics and other methods, I would like to show you that we have some platforms such as they are called multiplex PCR. One is the BioFire film array, and the other is the Curetis Univero. They include the detection of the most frequent viruses in bacteria, both in the community and in the hospital. And for that reason, the panel is called Pneumonia panel. Now we have the Pneumonia Plus. They are not different because they do not detect the same microorganisms. They have a turnaround time equal or lower than 2 hours or 5 hours for the Curetis. And the studies are ongoing, and now we have some randomized studies. Before these panels, we could use PCR techniques to detect MRSA, MSSA, some gram-negative Enterobacterales with some specific resistance. With the platforms, you can detect some mechanisms of resistance that are important to change the treatment. For example, the KPC in relation to carbapenemases, KPC, metallo-beta-lactamases, OXA48, imipenemases, and ESBLs. The mechanism of resistance detected are not the same when you compare the two platforms. In the meanwhile, and I know now other studies, this was, to my knowledge, the first randomized trial in patients with pneumonia, including ICU CAP, VAP, and HAP performed in the United Kingdom, and with the two arms, one using the FilmArray pneumonia plus panel and procalcitonin, and other, the intervention arm, that were randomized to a standard microbiological investigation, but here including the multiplex PCR for viruses. They could study 100 cases and 100 controls. And the results were the following. The time to results was obviously lower by definition in the group of samples that were analyzed by the multiplex technique. A credible pathogen was detected in 71% of the patients in the group of intervention. 80% of the intervention arm patients received directed therapy compared to much higher compared to the control arm. The time to results to directed therapy was 2.3 versus 46.1 in the control arm. 42 of 100 patients had resulted direct de-escalation, which is very important, compared with 8% only in the control group, and the time to de-escalation was much lower in the intervention arm compared to control arm. In summary, this was the first randomized study of rapid syndromic molecular testing in pneumonia, including CAP, including ICU CAP, including HAP and BAP. Obviously, this test detected more pathogens. The molecular results were generated much more rapidly than culture, and more patients had early appropriate antibiotic de-escalation, de-escalation, and escalation. These were not reflected in the final outcome of the patients, and we need probably larger studies to confirm the outcomes. But again, I think that these are useful techniques to be included in the management of severe CAP. Let's move to the second question of the PICO. So when severe patients with ICU admitted with severe CAP, very often have severe hypoxemic respiratory failure and non-hypercapnic, usually. When they have hypercapnias because they have a COPD concomitantly, or because they are really exhausting and dying. And the question was, because it's not solved, that in a hypoxemic patients with severe CAP, can either non-invasive mechanical ventilation, CPAP or BiPAP, or high flow nasal oxygen using nasal probes, rather than supplemented standard oxygen administration to avoid intubation and reduce mortality. This has been, or this is still a relevant question for severe COVID patients. The recommendations, after looking at a couple of studies, randomizing a couple of observational studies, is that in patients with SCAP and acute hypoxemic respiratory failure not needing immediate intubation, we suggest a standard starting with a high flow nasal cannula instead of a standard oxygen. Conditional recommendation, very low quality of evidence. Non-invasive mechanical ventilation, either CPAP or BiPAP, may be an option in certain patients with persistent hypoxemic respiratory failure not needing immediate intubation, irrespective of the previous use or not of high flow nasal cannula. Conditional recommendation, low quality of evidence. What we have observed in COVID, I'm not showing studies, but I think that from our part here, and we have a couple of publications of that the use of high flow nasal cannula in our large series of patients with COVID increased the survival of the patients, especially if there was not a delay of intubation. And again, we observed, there's something under revision, that the lesions of post-COVID observed are more associated with the use of non-invasive mechanical ventilation than the use of high flow nasal cannula. High flow nasal cannula is more comfortable, provides a high fraction of inspiratory fraction of oxygen, and it is very well tolerated usually by the patient and probably induces less damage, self-induced damage to the patient with severe CAP and ARDS. Let's move to the PICO number 3. And the PICO number 3 was, when using initial empiric therapy for SCAP, should a macrolide or fluoroquinolone be used as part of the combination therapy to reduce mortality and adverse clinical outcomes? Well, the use of macrolides, the addition, is because you have to cover Legionella and atypicals, and the observational studies have shown better outcomes when using macrolide compared to a quinolone, because macrolides have an important immunomodulatory action. The recommendation is we suggested the addition of macrolides and not fluoroquinolones to beta-lactams as empiric antibiotic therapy in hospitalized patients with SCAP. But again, conditional recommendation, very low quality of evidence, almost absence of specific randomized clinical trials. But the task force also considered the duration of treatment of macrolides being between 3 and 5 days. There is no clear information on that, but this depends on the type of macrolides that you use. This would be a reasonable timing, specifically in the context of de-escalation therapy. Let's see some remarks. In the ATS-IDSA 2019 guidelines, the recommendation for CAP admitted to the ward was a vital or to the unit into intensive care. This is intensive care, a beta-lactam plus a macrolide, and they said this is a strong recommendation, moderate quality of evidence, or a beta-lactam plus a respiratory fluoroquinolone, a strong recommendation but low quality of evidence. So they prefer this combination. So again, I want to say that it seems most of the observational studies show better outcomes when adding macrolides to beta-lactams. What about beta-lactams? And this is some novelties of the ATS-IDSA guidelines 2019. For example, intravenous cefuroxime was removed from the list of beta-lactams and ceftaroline was added. Ceftaroline is a 5th generation cephalosporin that in regulatory trials and in the randomized clinical trials showed to be superior in relation to clinical cure when compared to ceftriaxone in CAP caused by strep pneumo and methicillin-sensitive Staph aureus. I will come to Pseudomonas later on. But which macrolides? We usually use azithromycin, but we know that the levels of azithromycin in blood are not perfect. And this author, Giamarellos Bourbulis, was the senior author in this study, comparing a retrospective study, the 28-day mortality, comparing for groups of antibiotics given to patients with severe community-acquired pneumonia, and they found that the combination of clarithromycin plus beta-lactam, usually ceftriaxone, resulted in better outcomes even when compared with azithromycin plus beta-lactam. I don't know, this has to be reproduced in other trials, in other randomized trials, but it's going to be very difficult because clarithromycin is not available in many countries. I don't know what happens in your country. These are the results, the combined results for ceftaroline, a 5th generation cephalosporin, that were published several years ago, but up to now, the results were not really recognized because Pfizer took, not well, 4 or 5 years ago, took the responsibility of this, bought this drug to another industry. You can see here that for clinical cure in Focus 1, Focus 2, the regulatory trials, and the Asia CAP, comparing to 1 gram ceftriaxone or 2 grams in the Asia CAP, there was a superiority in the clinical response. What was the outcome asked by the regulatory agencies, and this was especially in Streptococcus pneumonia and Staph aureus. And this is the meta-analysis published with all these studies, and you can see here that for most of the population in the clinical, in this study randomized, the total result. This is the modified intention to treat population, and this is the clinically evaluable population, and the resultant was a better clinical cure and a better clinical response with ceftaroline. And for me, this could be a very good drug to use in severe community acquired pneumonia. Let's move to the PICO question 4. And this is associated or related to the use of biomarkers. Procalcitonin is a biomarker that in many countries is used in the initial evaluation of pneumonia, is available to be measured in the emergency department very quickly, and it has been used in randomized studies to distinguish viral from atypicals from bacteria. We realize that when using PCT for giving or not giving antibiotic or given different types of antibiotics, there are a lot of problems with the sensitivity. And the cutoffs used were not the same. So I think, and you have to take into account another issue, which is the following. This is a study that we published in 2018, and we look at biomarkers, in that case PCT, in a cohort of community-acquired pneumonia patients. We studied this in a derivation cohort and in a validation cohort, and we divided the patients in less than 3 days or more than 3 days regarding the initiation of the symptoms. This is not usually recorded, and this is important because the levels are not the same. They change after 3 days. The levels of PCT decrease, as you can see here, for the overall cohort and for the patients with CAP and sepsis. And this is the inverse with CRP, so that means that single determination is probably not useful to guide your initial antibiotic treatment. So I would not do that. And then, according to that, we focus in the duration of treatment. And according to the studies that we found, we suggested the use of procalcitonin to reduce the duration of antibiotic days in patients with SCAP. This was a conditional recommendation with a low quality of evidence. Remarks. The recommendation for using either PCT must be considered together with clinical assessment with the aim of reducing antibiotic treatment. But PCT might not be useful when clinical stability is achieved, because this is not going to see, the clinical stability parameters are not going to be better than PCT, and then you can stop the treatment here. Next, question 5 is very simple, and I don't know if this is your standard of care, but should oseltamivir, because at that time, influenza was very important. This was before COVID, and we see many patients with influenza now in the ICU, combined with bacteria or alone. Mostly combined with bacteria in the ICU. Should oseltamivir, an anti-influenza treatment, be added to standard therapy in patients with SCAP and confirmed influenza? No trials about that. Just observational in patients admitted to the hospital. We suggest to use oseltamivir for patients with SCAP when there is a confirmation by PCR technique, but conditional recommendation, very low quality of evidence. And when PCR is not available to confirm influenza, we suggest the use of empirical oseltamivir during the influenza season. But it again is conditional recommendation, very low quality of evidence. I think they have to use your common sense and the data in the community. You are plenty of influenza cases, and then I would probably add influenza in the treatment of the empirical treatment of a CAP until we have a confirmation. A burning question. the 6. So you know that with antibiotics, probably we are not going to improve the outcomes of our patients if you are following all the standards. And then we thought several years ago that the addition of steroids could both modulate the systemic and the local inflammatory response, and steroids could improve the outcomes, especially in patients with a very high inflammatory profile. And then the recommendations were the following. In patients with SCAP, we suggest the use of corticosteroids, mainly if shock is present, but this is conditional recommendation and low quality of evidence. Remarks. Based on common exclusion criteria from clinical trials, the recommendation does not apply to patients with viral influenza, SARS, and MERS, uncontrolled diabetes, and corticoid steroid treatment for other reasons. When corticoid therapy is considered at that time, and we closed our stage in December 2022, we recommended methylprednisolone 0.5 milligrams per kilo per 12 hours for 5 days. We said this is a reasonable option, and we used this dosage from a study that we published in JAMA. But probably this is not the final truth, because the following. Well, let's go to the guidelines ATS-IDSA 2019, and they said the new guidelines recommended against routine corticosteroid use for CAP overall. Okay, that's okay. And then this is a meta-analysis showing in observational studies that corticosteroids improve mortality in CAP. But we do not have really good studies on that. Let's go to some meta-analysis to reevaluate what we said. Well, for example, this is a meta-analysis that in CAP overall, published in Medicine, and they said that not hydrocortisone, comparison to hydrocortisone, improved the outcomes in CAP. Let's see more information. This is retrospective data from blood samples collected from a randomized clinical trial. And these German and Dutch researchers found that only in patients with a high level inflammation measured by interleukin-6, by MCP, and high levels of interleukin-8, corticosteroids were effective in decreasing mortality. So we have 2 points here to be discussed. One, hydrocortisone versus methylprednisolone, high inflammatory profile or not, and another one that you will see. We look at the association with macrolides and glucocorticosteroids in this study published in PLOS ONE from our randomized clinical trial data, and we did not observe changes in the outcomes when adding corticosteroids to macrolides. So macrolides seemed not adding further anti-inflammatory effects to corticosteroids. And then in the 2020 and 2022, other meta-analyses show up. This is during the pandemic. And if you look at here in severe community-acquired pneumonia, these were the studies included that overall they favor corticosteroids to decrease mortality in severe community-acquired pneumonia. But these studies, some of them used dexamethasone, hydrocortisone, and some others methylprednisolone. The dosages were not the same, the duration was not the same. Another meta-analysis published this year in 2023, they included 16 trials, including SCAP and non-SCAP. They found no difference in mortality, but the reason is that they mixed SCAP and non-SCAP. Corticosteroid therapy was associated with a lower incidence of progression to requiring mechanical ventilation. That means that if you use in a very severe patient with acute respiratory failure corticosteroids, you have to give them really very early. Some issues that we observe in this meta-analysis that is important are the side effects. Not important except for the readmission of patients more frequent in the corticosteroid arm versus the non-corticosteroid. So look at here the signal that favors placebo. And after that, the trial of the Veterans United States was published with a lot of patients with SCAP minor or major criteria, and they did not conclude the trial because they could not include all the patients that was from the initial design, but they concluded using methylprednisolone for 20-day treatment, which is a lot to me, that in patients with severe CAP, prolonged low dose of methylprednisolone treatment did not significantly reduce 60-day mortality and 1-year mortality, but treatment was not associated with increased complications. If you go to some details of the trial, you can see that patients with corticosteroids has the half of the days of mechanical ventilation compared to the others. And we did some in the guidelines. We did some meta-analysis, including the Meduris trial for 60-day mortality, for ICU mortality, for ARDS, for 3 days of mechanical ventilation. I'll show more about that. And what we found for overall, no difference in echo mortality, but then this paper was published very recently, March this year. This is a study from the French group. They included 800 patients. They used hydrocortisone. They excluded patients with more than 3 days of shock. And they found giving hydrocortisone and IV and tapering down the following. And this fits with our recommendation, okay, is that a decrease in mortality, mainly in patients with septic shock. Here is not included the Kansas study. This is the meta-analysis of the guidelines, and shock of any cause. And this fits with the Kines study. So the question is, only in SCAP with shock? This is something for the debate. Do we need further additional randomized clinical trials? Well, a small population in some trials, but now we have big studies, the veterans and the French study. Inflammatory status often not considered in the inclusion-exclusion criteria. This is true. And I think that the inflammatory phenotype, like we have seen in COVID, is the target population. Now it seems that the target population is shock, but usually shock and inflammation coincide. Many trials included non-severe CAP, so we have to go to SCAP, and the corticosteroids dosage and duration highly heterogeneous. And now the question is hydrocortisone versus methylprednisolone. So long question, difficult question. I am going to the last 2 questions, and I think that I use it around 40-45 minutes. The next question to those difficult to treat are not the core pathogens in the, hold on. I had the problem with the internet connection now. Okay, these are not the core pathogens, and they are sometimes treated with standard treatment. And the question is, does the use of a prediction score for drug-resistant pathogens lead to more appropriate therapy and improving outcomes? And this includes mortality, treatment failure, duration of antibiotic therapy, prolonged ICU stay. These questions cannot be answered, but the panel suggested integrated specific risk factors, eventually computed into clinical scores, or even into artificial intelligence systems, but based on the local epidemiology and previous colonization mainly, to guide decisions regarding drug-resistant pathogen. We exclude here the immunocompromised. We are not talking today about immunocompromised patients. For the empirical antibiotic prescription of SCAP patients, conditional recommendation, moderate quality of evidence. I'm going to show what we are using. The ATS-IDSA guidelines, they also recommended more or less the same. Use locally validated clinically biological scores. Well, which are the microorganisms that you can find problems with the standard treatment? Well, what we call PES. P stands for Pseudomonas, E for ESBL producers, and S for MRSA. All of these microorganisms are not covered by the standard treatment of third generation beta-lactamase plus macrolide. So we found, and we validated in SeverCap as well in the 2022, that using this simple score that includes age, male, previous antibiotic use, chronic respiratory disorder, chronic renal disease, and at emergency, consciousness impairment, and the presence, absence, or fever or shivers, and these are the points given after several analyses, you can say that when the score is 5 or higher, the percentage of positivity of these microorganisms is very high. This can help you to use or to induce to use molecular platforms in that population if possible. Let's move to the last question, as is regarding aspiration pneumonia. Aspiration pneumonia represents an important proportion of patients with severe CAP, around 20%. The definition is difficult, this is the first point, and the treatment is debatable, the treatment that we are doing now. And the question was, do patients with severe CAP and aspiration risk factors have better outcomes, mortality, length of stay, treatment failure, if treated with a risk-based therapy regime instead of a standard CAP antibiotics? We cannot answer that question because there are no randomized trials about that. But based on the epidemiological studies that we found in the literature, we recommended the following. In patients with SCAP and aspiration risk factor, for example, unobserved aspiration or a patient with coma, we suggest to use the standard CAP therapy regime and not a specific therapy targeting anaerobic bacteria, because the anti-anaerobic treatments, for example, amoxicillin clavulanate, piperacillin tazobactam, others, produce more harm in the microbiota and macrobiome compared to the standard CAP therapy, and the isolation of anaerobes is always inexistent. This is a graded recommendation, good practice statement. And the guidelines, ATS-IDSA said that adding anaerobe coverage might cause harm without added benefit. But I think, and this is a personal view, that there is a subset of population, for example, when there is an empyema or when there is pulmonary abscess, that could benefit from anti-anaerobe. We performed a meta-analysis that is in preparation now of a series of observational studies with patients with risk factors for aspirations in community-acquired pneumonia, and we observed that these patients usually have, with aspiration overall, ICU and non-ICU, a higher length of stay and a higher risk of ICU and mortality. So really, this is a population that is very frequent that we need more information, more studies, and we should see, but this is difficult, if the standard of treatment recommended for CAP is followed by better outcomes compared to anti-anaerobic treatment. This is my last slide. I want to thank you for your attention, and I hope that I met with your expectancies, and thanks again for your kind invitation, both Professor Reviono and Adrian. Thank you very much.
Wait, I will. Okay, thank you very much, Prof. Torres, for your kind presentation. Very interesting lecture. It was detailed, systematic, and give us insight or another point of view on how to manage the patients with severe community-acquired pneumonia. Okay.
Yes, you can include questions about CAP as well. No problem.
Okay.
CAP non-severe, whatever you want.
Okay, thank you, Prof. Okay, now let us move on to the discussion session. There are some questions here, Prof, maybe about 13 questions already. Okay, would you, the committee help me to present the questions, the PowerPoint? Wait. Okay, maybe I can read the questions first. Okay, the first question, Prof. Torres, related antibiotic therapy and comorbidity. From Prof. Reviono and also Dr. Pras, a pulmonologist from UNER, yeah, Prof. Reviono from Medical Faculty UNS and Dr. Pras, pulmonology from UNER. In these lectures, it said that most of the selection of empiric antibiotics is based on possible causative pathogens. Thus, the presence of comorbidities such as diabetes, kidney failure, heart disease, HIV influence the selection of empiric antibiotics in severe pneumonia. And then, is it possible to use one single potent of antibiotic in severe CAP if the other antibiotic is contraindicated to the patient because of severe cardiac rhythm dysfunction and severe renal problems? Okay.
Okay, these are good questions about when is first comorbidities, the role of comorbidities. And for example, in previous CAP guidelines, the risk of comorbidities in relation to Pseudomonas aeruginosa was quoted. And this is most importantly found in patients with bronchiectasis with a lot of antibiotics administered previously, or even with previous colonization, which is frequently known in patients with bronchiectasis. If the patient is colonized, a patient with bronchiectasis with Pseudomonas aeruginosa, and the patient has community-acquired pneumonia, you have to cover Pseudomonas. In COPD, very advanced COPD, probably it's the same. Okay, and then HIV patients have with a normal immunity. I'm not talking about those with a low level of CD4. You have to use the same antibiotics. If you cannot use a second antibiotic, let's say macrolides or quinolones before giving the empiric antibiotic therapy, you cannot use. Of course, that you can use a single antibiotic. According to the literature, this is not going to be the same. But in that case, I recommend to use a more potent antibiotic, such as a more potent beta-lactam, ceftaroline, in that case. And in kidney failure, heart disease, diabetes, there are not particular differences as regarding the etiology to my knowledge. I think that you have to use a series of risk factors, as mentioned in the 2007 guidelines of community-acquired pneumonia. And in influenza, you are right that for early bacterial co-infection, Staph aureus and strep pneumo are the more frequent co-infectors during the first 3 days. In a series of patients admitted to the ICU in a publication comparing to COVID, 30% of the patients, 30, were co-infected by Staph aureus as strep pneumo. Then I recommend in that specific population to treat them for ceftriaxone plus a macrolide if possible. Of course, the macrolide is given because you have to cover Legionella and atypicals or for immunization. So I recommend the macrolide as much as possible.
Okay, microlide. Okay, will be the choice. Okay, next question. Okay, I see here there's one raised hand from who? Dr. Leah. Dr. Leah, can you hear me? Dr. Leah?
Yes, doctor.
Okay. You may ask the questions to Prof. Torres directly.
Okay, thank you, doctor. May I ask one question about the corticosteroid, doctor? So in patient with severe C8, community-acquired pneumonia, we can use corticosteroid. How about adjusting dose with corticosteroid itself, doctor, in patient with diabetes mellitus or maybe another comorbid, doctor? And how we evaluate the management with corticosteroid itself, doctor? Thank you.
Yes, this is a question about the dosage. Okay, the one point is diabetes mellitus. When you give corticosteroids to a diabetes mellitus patients that needed insulin before admission, corticosteroids are going for sure to make problems with insulin. The necessities will increase. And then, but you have to put in the balance what is the best to dysregulate glycemia levels or to cure or decrease mortality with corticosteroids. So you have this should be individualized in patients with diabetes mellitus. I have seen some patients that had to stop corticosteroids. I have to say that is important. About the type of corticosteroids, hydrocortisone was the drug studied by the French study in the New England Journal of Medicine that decreased mortality in patients with shock. Is the drug used by Confalonieri, one of the first studies. The authors found mortality 0, which is very difficult to understand in patients with corticosteroids. Mortality 0, severe cap compared to mortality 25–30%, no corticosteroids. And then in sepsis, in these patients is indicated as well, they use hydrocortisone. They can use it 200 milligrams every 12 hours. So now the question is, which drug we have to use? I think that after the study of the CAN and the studies on sepsis and septic shock, probably we have to use hydrocortisone instead of methylprednisolone. We used methylprednisolone because we studied this in animals and we found some positive results. But I think that I recommend now using hydrocorticosteroids, but we need to do some randomized studies or some studies on that.
Thank you, Dr.
Okay. Thank you, Prof. Torres. You also already answered another question that related to corticosteroid. And can we go to the next questions, please? Okay. And now questions about management of SCAP and the comorbid from Dr. Indah, pulmonologist from Suraji Kalaten Hospital. She asks, what's your recommendation related to the management in SCAP with comorbid, unresponsive initial treatment, and in severe SCAP plus stroke? What is your recommendation about antibiotic inhalation therapy?
Okay, this is a good question because sometimes in these patients with comorbidities, they are not responding to the initial standard therapy, and you observe what is called treatment failure, or early or late treatment failure. I think that then in that population, you have to suspect non-core microorganisms, such as Staph aureus, methicillin resistant or not. Well, Staph aureus is a core one, but Staph aureus methicillin resistant, Pseudomonas aeruginosa, or Enterobacteriaceae, ESBL or resistant to carbapenems, or even sometimes, depending on the epidemiology of your country, Acinetobacter. What you have to do is to revise the microbiology. This is a population to perform molecular tests, rapid molecular tests. Careful, because when the patients are intubated, you might have super infections. And then probably you have to move to, before having the results, to a change in the empirical antibiotic treatment. And then I would move to carbapenems, for example, or carbapenems plus linezolid, for example. This could be a good option. And then you cover that way Pseudomonas, you cover gram-negative bacilli, you keep covering strep pneumo, and you cover Staph aureus methicillin resistant. Meropenem plus linezolid is a good option, but it is a better option to try to obtain an etiological diagnosis, microbial etiological diagnosis. There was another question here, no? A second one.
Yeah, the second one. Wait. What is your I'm sorry. Okay. What's your take on choosing antibiotic for geriatric patients or immunocompromised patients, such as patients with lung cancer? What is your preference?
A difficult question. Usually we use the standard therapy for these patients, but of course they can have other microorganisms, and I strongly recommend to go to the risk factors for Pseudomonas, for Staph aureus, and to look at the score that you have, or to, in this population, try to obtain a respiratory sample, which is easy in intubated patients, and to perform the standards, the gram stain, the culture, and molecular test if you can do it. Because in some population of geriatrics, and indeed, age was one of the risk factors for the score PES, but age alone is not enough. And usually the elderly population have other comorbidities that you have to take into account, usually, when they develop pneumonia.
Okay. Maybe there's somebody raise hands. Anyone? Okay. For the next question. Okay, wait. Wait, the questions. Okay. Okay, there's a question from Dr. Linda Subroto, pulmonologist. In severe CAP, if we found that the result of sputum culture is normal or maybe no growth, yeah, or maybe still a commensalis or a colonization from the respiratory tract, it's still rational to continue the empiric antibiotic treatment?
Well, in using the standard cultures and in presence of prior antibiotic treatment, which is very frequent, because so these patients can have received, when they start the disease, antibiotics in the outpatient care, or they can receive antibiotics in the emergency department, and then the sample is taken after that. So the cultures can be negative in a lot of them, And of course, if your clinical suspicion of pneumonia, you have to follow with the standard care and to look if the patient is doing well or not, to look for early treatment failure and to look for late treatment failure. And there is another
Yes.
question.
Yes, from Dr. Bella, pulmonologist resident. When is the recommended time to perform PCR test in CAP?
Well, when the patient is arriving at the emergency department, I think that it's time to take samples and to perform that. But I have to say that PCR are not modified, PCR results, no, they are not mainly modified by previous antibiotic treatments for bacteria. This is important, and not modified for viruses. Then this is an important advantage that I did not mention before.
Okay. Is there any questions? Questions related with antiviral from Dr. Tika, pulmonology resident. Is the usage of oseltamivir as antivirus is applicable in Indonesia or other tropical countries? What do you think, Prof. Torres?
This is a good question because it depends on the epidemiology of influenza. And then you have to know when you have, if you have influenza season. This is something that you have to know. And in other tropical countries, it's the same. Maybe this question is not applicable.
Okay. So now maybe in our country, there's a change in weather very quickly. So everyone get cough, get influenza. So maybe oseltamivir, we can use oseltamivir here in Indonesia, maybe, yeah? Depends on the condition and the influenza seasons, like you said.
Exactly.
Okay. Maybe the second question is also similar with the first one. So another question from Dr. Gemilang, pulmonologist from UNRAM, RSUD Provinsi NTB itu berarti West Indonesia, ya, Nusa Tenggara. When do we start prophylaxis with antifungals in severe CAP that is prolonged with a ventilator?
Okay, this is a good question as well. You know that fungi is a complication of pulmonary fungi infection, especially Aspergillus, is a complication of mechanically ventilated patients, and it represents around the 12% of patients with ventilator-associated pneumonia. Thus, I think that in patients mechanically ventilated with SCAP, if there is treatment failure, especially late treatment failure, you have to perform a bronchoscopy with bronchoalveolar lavage. You have to culture for fungi. You have to do the adequate stains, and importantly, you have to look at the galactomannan in BAL to see if the patient has elevated levels. So it's very difficult. I would not give prophylaxis as prophylaxis. Usually what we have to do is initial rapid suspicion. There are some factors, for example, a severe COPD, prior use of antibiotics, and prior use of corticosteroids and malnutrition for fungi. And then you have to look carefully to that in a patient with community-acquired pneumonia that is not responding well to the treatment.
Okay, so depends on the clinical of the patient. If there's patient have a risk factors for like a possible mycosis or probable mycosis, and also if we evaluate the candida score, with the candida, can we use that? Can you use that score to give antifungals to the patients?
Well, let me tell something. The lung candidiasis is not existing.
Okay.
And we demonstrated you do not have to treat with antifungals, anti-candida, okay?
Okay.
To patients in whom you have a respiratory culture with the growth of candida.
Any kind of candida. So because we have so many culture of fungals that we found like candida glabrata or candida something. So actually we don't need to give the antifungals to the patients.
I don't think so, because candida is not a pathogen for the lung, especially for the lung. I don't know if a specific species of candida with resistance can cause, but I have not seen that, and we published a paper in Clinical Microbiological Infection about that, about the role of candida colonization in respiratory secretions. But other thing is that if you suspect invasive candidiasis, which is a complication of mechanically ventilated patients, and then you have to use the recommendations for that. The FUNDIQ or FUNDIQ group, the FUNDIQ is going to release some recommendations and definitions for that, both for research and for treatment. Okay, but our recommendation is if you do not give antifungals based only in the isolation of candidas in respiratory cultures.
Okay, noted, Prof. Thank you very much. There's another questions from Drs. Hendra Suti, pulmonologist. Okay, also Dr. Arisma and also Dr. Indah. Similar questions about antibiotic therapy. Patient with severe pneumonia with sepsis, sputum culture is difficult to obtain samples. The result, blood cultures, no growth, and given empirical therapy does not improve. What could we do when encountering severe pneumonia that doesn't respond to antibiotic? Is there any alternative therapy? And also from Dr. Indah, often we found from the sputum culture in invasive mechanical ventilator patients, Acinetobacter baumannii with resistance for many antibiotics, except cotrimoxazole orally. But when we gave it, no improvement clinically. Is it rational give orally antibiotic for such patient, and what should we do?
Well, as regards the first question, again, I'm going to repeat what I said before. When the patient is not performing well and you have criteria for failure to antibiotics, you have to reevaluate the cultures, the first, to obtain respiratory samples with a bronchoscopy if possible, and even you have to perform to CT scan if there is a complication. And then to move to a second option, and I recommended meropenem plus linezolid as a second option. Okay? As regards the question, you refer to a patient with Acinetobacter resistant to all antibiotics, except trimethoprim cotrimoxazole. no?
Yes. Yeah.
But you can use trimethoprim cotrimoxazole in IV form. You do not have to give oral antibiotics to them most of the time.
Maybe here we don't have it, Prof. So we only have trimethoprim sulfamethoxazole in oral.
This is the reason. Okay, this is the reason of that. And then in that case, well, I am not sure that oral is a good option.
Okay.
We do not know, at least I don't know which is the absorption level of trimethoprim cotrimoxazole in mechanically ventilated patients with an NG tube, etc., etc. And then I don't know if you have that drug for Acinetobacter, which is cefiderocol. Cefiderocol is a new antibiotic.
Okay.
That is active against Acinetobacter. Another possibility is to give a combination. Well, no, this is for metabolactamases. You can combine. Well, if you do not have cefiderocol, then and you cannot, and you only have oral trimethoprim cotrimoxazole, you can do combinations of antibiotics as we did before the new antibiotics were available. For example, tigecycline, fosfomycin, and inhaled amikacin, because I suspect that this Acinetobacter was sensitive to amikacin.
Okay. Okay. Thank you, Prof, for the very clear explanation about the antibiotic preference. Maybe this is the last questions, Prof, from the participants, from Dr. Levy and Dr. Ririn, pulmonologist residents, about evolution of culture microorganism in severe CAP. Does it need to be repeated or not? How many days does it need to be repeated? And then is every patient with severe CAP, we have to check the procalcitonin level in the first admission in emergency ward? And what is the best time to check the procalcitonin?
Okay, good questions. As regards the first one, I think if it's easy to obtain a valid sample, you need to reevaluate the culture and the stains in a sample obtained between days 4 and 5, because these are the days that you evaluate the early treatment evolution. Okay, so 4 to 5 days, 4 to 6.
4 to 6 days, so we need to repeat.
Yeah.
Okay, the culture.
Especially when the patient is mechanically ventilated, because it's easy to obtain a sample. I think you have to do that, because you will see a decrease in the burden of microorganisms or absence of strep pneumo that you found in the first evaluation, or if the patient is not doing well, you can see another microorganism, which happens. I think this should be a regular practice. The other thing is about procalcitonin. Procalcitonin, now all emergency departments are doing procalcitonin. Okay, so the first sample is obtained at the emergency department, but you have to take into account to evaluate the level of procalcitonin. And as I said, you cannot use procalcitonin to give or not to give antibiotics. You have to take into account the number of days when patient initiated the disease, as I showed you before. This is important, and nobody's doing that. And a single sample is not useful, and you have to compare two samples. And for SCAP, the main utility of procalcitonin is probably the duration of antibiotics.
Okay, so we check the procalcitonin not for when we use the antibiotic, but how many days or how long we use the antibiotic.
Oh,
Like that, Prof.
Exactly, and you can obtain a second sample on day, let's say 7, and then you can see the level, if procalcitonin decrease importantly, can help to your decision to stop antibiotics. But it's not only procalcitonin. The clinical signs and symptoms are very important: oxygenation, chest X-ray, ventilatory parameters improved, absence of fever, decrease in CRP. I think that you cannot, there is no biomarker in infectious disease 100% sensitive and specific.
Okay. Okay, thank you, Prof. Torres. And maybe for the last one, I will read the comment from the chat column from Dr. Jatu Apridasari, pulmonologist consultant. She said, thank you to you, Prof. Torres. I fully agree with your previous statement about antifungal treatment in pneumonia with infection of Candida species. I have the same opinion as yours. Looking forward to see you in person to have further discussion.
Okay, thank you. Thank you very much for this comment.
Okay, maybe that's all questions for all participants. Prof. Torres, thank you for your brief, very well explained and very clear explanation to us. So maybe please let me conclude a little bit from our guest lecture today about the latest criteria of severe CAP, major and minor criteria. So it was should propose new definition as severe CAP related to high, early, and late death cases following 1 year after severe CAP infection. And severe CAP defined as CAP patients admitted to the ICU. And also Streptococcus pneumonia represent nearly half as etiology of severe CAP. Polymicrobial etiology occurs mostly in mechanical ventilator patients. Only bilateral infiltrate and lymphopenia correlated with worse outcome and increased twofold mortality risk. Also about multiplex PCR is recommended during faster result, proceed to escalation or de-escalation of antibiotic therapy. Also about the oxygen therapy, HFNO is suggested instead of standard oxygen therapy in severe CAP when the patient have an acute respiratory failure and not needing immediate intubation. And combination of macrolides and beta-lactams as empirical antibiotic therapy in hospitalized patient with severe CAP will be recommended at the first, maybe the first choice right now, the best first choice right now. And also evaluation of culture microorganism in severe CAP should be repeated in 4 until 6 days. Oh, I'm sorry. Oh, okay. And also about the procalcitonin, that's a good parameter for good parameter for know that there is a bacterial infection on the patient, but we cannot use the procalcitonin level to decide when we use the antibiotic of the patient, but maybe we can use it for the evaluation for how long we use the antibiotic to the patients. Maybe that's more or less of the conclusion of the guest lecture. Thank you, Prof. Torres, on behalf of the Pulmonology and Respiratory Medicine Department, Medical Faculty of University 11 Maret. We would like to express our immense gratitude to Prof. Torres for his willingness to deliver today's guest lecture. Thank you very much. Muchas gracias. Am I saying it correctly?
Yes, you said it. You said it perfectly. Artem,
Okay.
it was really my pleasure. Thank you very much.
Thank you very much. Until we meet again on another question, I hope that we can collaborate on a project in the future, Prof.
And I hope so.
Yes. Okay. Maybe someday. Okay, and we also appreciate the active participation of all the participants in this lecture. We hope that the knowledge we have gained today will be beneficial to our daily clinical practice we provide to our patients. Also, apologies for any shortcomings and unintentional mistakes that may have caused any inconvenience or dissatisfaction. I will now return the time to Dr. Tiur. Thank you.
Thank you, Mrs. Atrin Adiputri, medical doctor, pulmonologist, consultant, master of biomedicine. Thank you, Professor. And muchas gracias, Professor. Here is a host for today, and unfortunately, we have finally come to the end of this international guest lecture. Before I close this session, I would like to give a further information that there will be an upcoming information about the international lecture from National Cheng Kung University, Taiwan, in 30 May 2020. Last but not least, we would like to thank Professor Antoni Torres, medical doctor, PhD, FIPRS, FCCP, ATSF, as our guest lecturer, and also Mrs. Atrin Adiputri, medical doctor, pulmonologist consultant, master of biomedicine, as our moderator. Professor Dr. Reviono, medical doctor, pulmonologist consultant, fellow of Indonesian Society of Respirology, as our dean. Professors, pulmonologists, consultant, all the resident doctors and participants. See you and adios.
Adios. Thank you very much.
Adios.
Goodbye.
Adios.
Thank you, Antoni. See you
Thank
next time.
Bye.
Bye-bye.
Bye.
Bye-bye.
And for the participant, we remind you to fill the attendance list, and the list can be accessed in a chat column. Thank you.
See, I've always been a fighter, but without you, I'd give up. And I can't sing a love song like the way it's meant to be. Well, I guess I'm not